Welcome to this clinical explainer. We're diving straight into the high-stakes escalation pathway of pancreatic disease. We're going to track a patient's journey from their first moments in the emergency bay, right through the ICU and surgery, all the way to the oncology clinic. Let's jump right into our first clinical challenge. A 60-year-old male with a history of alcohol abuse presents with severe epigastric pain radiating directly to his back. What is the best initial diagnostic test? The correct answer is measuring serum amylase and lipase levels. This is your fastest baseline confirmation. Remember, you only need to hit 2 of 3 criteria for a clinical diagnosis: that characteristic pain, a 3-fold bump in those enzymes, or positive cross-sectional imaging. Now, you might be thinking, hey, why not just grab an ultrasound? Well, in this acute setting, it's practically useless. The secondary ileus creates all these overlying bowel gas shadows that completely obscure the retroperitoneal pancreas. When we compare these two enzymes head-to-head, it's super clear why lipase is the preferred marker. Amylase has a really short half-life. It normalizes super fast. And worse, it can totally trick you with false elevations if the patient actually has a perforated ulcer or bowel ischemia. Lipase hangs around longer and gives you way better specificity for actual pancreatic inflammation. Okay, let's look at another scenario. A 45-year-old male is evaluated following high-velocity blunt abdominal trauma from a motor vehicle collision. Which statement is correct regarding pancreatic injury? The correct statement is that the most common cause is blunt abdominal trauma. The key here is picturing the mechanism. Imagine the patient's abdomen hitting the steering wheel. The deep pancreas literally gets crushed transaxially directly against the rigid lumbar spine. Now, don't let early enzyme levels fool you here. They are highly insensitive right after trauma, meaning normal enzymes absolutely cannot rule out a parenchymal laceration. You need the gold standard, a contrast-enhanced CT of the abdomen, to map out the damage. And speaking of things you don't want to see, whether it's from trauma or severe necrotizing disease, retroperitoneal blood can track outward. If you spot colon sign around the belly button, Gray Turner sign on the flanks, or Fox's sign down over the thigh, pay extremely close attention. These dark ecchymosis patterns are terrifying cutaneous markers. They mean severe hemorrhage and a remarkably high risk of systemic mortality. Escalation to the ICU, organ failure, severity scoring, and the threat of sepsis. Once your patient hits the ICU, you have to know exactly how sick they are. And the absolute height of those amylase and lipase numbers won't tell you. Instead, you categorize severity using the 48-hour organ failure benchmark. If organ failure, like shock or renal failure, persists beyond that critical 48-hour window, you have crossed into the severe, life-threatening category. To predict these outcomes, we lean heavily on scoring systems like Apache 2. Ranson's criteria make you wait 48 hours to compile the data, which is honestly agonizing. But Apache 2? It's completely dynamic. You calculate it right on admission and update it daily. It looks at 12 physiological variables, importantly including the Glasgow Coma Scale to track neurostatus. If you hit a score of 13 or higher, you are looking at a very high risk of multi-organ failure. Systemic risks aside, what's happening locally? As the disease progresses, which of the following structural transformations represents the most dangerous local complication lurking in the retroperitoneum? The correct answer is extensive pancreatic necrosis. This is basically a ticking time bomb. It defines zones of totally dead, non-viable tissue. The real danger here is that these dead zones practically invite bacterial translocation, specifically from enteric gram-negative bacilli like E. coli. What starts as sterile inflammation suddenly turns into a lethal infected state. This creates a really distinct bimodal mortality timeline. In that early phase, the first 48 hours to 2 weeks, the threat is third spacing, hypovolemic shock, and multi-organ dysfunction from massive systemic inflammation. But after 2 weeks, the killer completely shifts. Late-phase mortality is predominantly driven by that infected pancreatic necrosis and the resulting secondary sepsis. Surgical management. Navigating the pseudocyst pathway. Let's jump ahead a bit. A patient presents 6 weeks post-pancreatitis with an epigastric mass, early satiety, and a resonant percussion note. What is the most likely diagnosis? The diagnosis is a pancreatic pseudocyst. The absolute magic number here is that 4 to 6 week timeline benchmark. It takes exactly that much time for reactive granulation tissue to build a mature fibrous wall around that fluid collection. And that resonant percussion note you heard, that happens because the cyst is sitting right in the lesser sac, tucked directly behind the air-filled stomach. So how do we intervene? It's a strict stepwise algorithm. If it's uncomplicated and under 6 centimeters, you just track it. A lot of these resolve spontaneously. But if it's over 6 centimeters, mature, and causing symptoms like that early satiety, it requires surgical internal drainage. You absolutely never do blind external drainage on a clean cyst. Doing so risks creating a massive, non-healing pancreaticocutaneous fistula. For that internal drainage, anatomy makes the rules. If the cyst is tightly glued to the back of the stomach, you do a surgical cystogastrostomy, basically draining it straight through the stomach wall. But if the cyst drops down and bulges through the transverse mesocolon, pulling away from the stomach, a Roux-en-Y cystogiganostomy becomes your most anatomically reliable option. But what if things take a sudden turn? Say at week 5, the patient spikes a 102-degree fever with a huge white count, like 24,000. And their imaging shows a fluid collection with a rim-enhancing capsule. Don't let a normal amylase fool you. This is the definitive footprint of an infected pseudocyst. And the rules flip entirely. You must not perform internal drainage because of the risk of causing peritonitis. This demands immediate IV antibiotics and a percutaneous external catheter to drain the pus. The Oncology Clinic, evaluating obstructive jaundice and malignancy. Let's move to our final scenarios and talk about Courvoisier's law. It's an absolute clinical must-know. If you see progressive, painless, obstructive jaundice paired with a palpable, smooth, non-tender gallbladder, your brain needs to instantly pivot from painful gallstones to a malignant obstruction. You are highly suspicious of a carcinoma sitting right in the head of the pancreas. So, applying this, you have a 57-year-old male satisfying Courvoisier's law. What is the most appropriate next step to evaluate his surgical resectability? The correct answer is a contrast-enhanced dual-phase CT scan. This is vital to map out the local vascular relationships. But the huge takeaway here is the biopsy barrier. You must completely avoid a percutaneous transperitoneal biopsy. Sticking a needle into that mass carries a remarkably high risk of seeding tumor cells right along the needle tract and spilling them into the peritoneal cavity. The firm surgical axiom is this: if the CT shows a classic, resectable mass, you skip the biopsy and proceed directly to surgery. We've just navigated the entire clinical escalation pathway of pancreatic disease, from that strict 48-hour organ failure window to a 6-week pseudocyst maturation benchmark. Timing and anatomy literally dictate every single move you make. So when you're actually on the floor and the pager goes off, are you ready to trust these timelines and make the exact right intervention?